Hello everyone, welcome to HIM 216. We're on page 88 in chapter 5 of your textbook. And actually I want to go over exercise 5.5. In the first example, we have urinary tract infection, urogenital due to candidiasis. If we go to infection, urinary tract, we see the default code M39.0. When we go to that code in the tabular, we can see that we have an excludes note 1 for candidiasis of the urinary tract, B37.4. Well, of course, we can see that B37.4 is not a complete code. If I go to candidiasis, I'll see urethritis. That's not what we have. And then urogenital site NEC. And that is actually the code that we need to choose for this. Candidiasis, we don't have documentation that it's cystitis and urethritis. Those are specific areas of the urinary tract. Those are not documented. We don't have Belinitis documented, so the option that we have to choose from is other urogenital candidiasis. So B37.49. In the next question, number 2, we have streptococcal group A pneumonia or strep pneumonia. And we're going to put in pneumonia. Streptococcal group A, J15.4. So this is another combination code, just like the candidiasis was, pneumonia due to other streptococci, and this is the code that we would use. We would not have a code for pneumonia, J18.9, and then try to code the group A strep. We will use this combination code. And then food poisoning due to salmonella. If we go to poisoning and food, we can see due to and then salmonella, A02.9. That codes to salmonella infection unspecified. And this is in a category for other salmonella infections. And so that is the only code that we will use for this food poisoning. On the bottom of page 88, we have sequela, which are also called late effects. A sequela is when we have a condition that continues to that the patient continues to have after the acute phase of that injury has terminated. The classic example of this is a patient who's had a stroke and they have a sequela or a late effect of that stroke, and it could be paralysis on one side of the body or the other side. It could be trouble speaking. It could be trouble swallowing. It could be any number of things. Those are conditions that the patient has because of the stroke. The stroke damaged an area of the brain, and even though the patient isn't continuing to have a stroke, they have that late effect. Another example is scarring after a burn. Patients may have scars that are late effects of burns. Patients may have, there are some patients that develop what are called keloid scarring after they have, sometimes people get their ears pierced and then they develop these huge scars on their earlobes from that, having that ear piercing. That's a type of late effect. Your book tells you that there is no time limit on when a late effect can be used. As a matter of fact, it could be 15 or 20 years after the fact. it tells us that this residual can be apparent, such as sometimes the way that you know a patient is having a CVA or a stroke is because you can see the change in their body. You can see that their face is drooping or that they have lost control of one side of their body. A deviated septum due to a nasal fracture is considered to be a sequela. Infertility due to occlusion of the fallopian tubes from tuberculosis. You can have sequela from tuberculosis. You can have sequela from polio. And it's very important. Let me show you. In the index, literally, I go to the term sequela. And you can see sequela of cerebrovascular disease. And I'm going to pick aphasia, and we're going to look at that code. First, let me get to the beginning of this category. Well, let me find my little thing right here. Okay, so when we get to this particular category, it is sequela of cerebrovascular disease. You have a note here that tells you that this is used to indicate conditions in 160 to 167 as the cause of a sequela. There is an excludes note 1 here, and we'll talk more about these when we're actually studying this chapter. But you can see that this category does include sequela of a number of different conditions. This is a subarachnoid hemorrhage. All of these are going to be sequela of cerebrovascular disease, and we were looking at aphasia. So aphasia following unspecified cerebrovascular disease. In this instance, this one code actually covers the fact that they have aphasia and that they're having that they had a cerebrovascular disease. This particular, you have an instructional note here to use an additional code to identify the type of dysphagia, and because we have that particular instructional note, we would go to this category and add a code for the type of dysphagia that the patient has, and we'll study that more later. There is sequela of a cerebral infarction and sequela of a stroke, and then you can see sequela of tuberculosis. There should be poliomyelitis B91. And actually, when we go to each of the chapters, in some of them there is actually a category, sequela of infectious and parasitic diseases. And you'll see that your instructional note for these is to code first the condition resulting from the infectious or parasitic disease. So if we looked at sequela of TB, whatever that sequela was, that code would be sequenced first, and then we would use this sequela code. If we look at, we don't have a specific category for Chapter 2, not Chapter 3. And it's kind of spotty. Some conditions in chapters lead themselves more to having sequela than others. And actually, there are some, for sequela, there are some, do you see that in this superficial injury of head we have a 7th character? that indicates that the patient has a sequela, you actually code the you apply the code for the acute condition with the 7th character of S for sequela. This is particularly true of burns. If I go to this burn of the left upper arm and I look at my 7th character, sequela is actually the 7th character that indicates that this patient has a sequela of a burn of the left upper arm. So sometimes you go to for injuries, you go to the acute condition and then add an S to indicate that it is a sequela. For this lecture, I want you to exercise 5-6, answer number 1 and number 3. Now, looking at page 89, impending or threatened condition. If you have a condition that is described as impending or threatened at the time of discharge, if it occurred, you code it as a confirmed diagnosis. If it didn't occur, then in the index you go to see if the condition has a subentry for impending or threatened. You can also look at impending or threatened in the alphabetical index. So if I go to threatened, there it is, threatened abortion, threatened labor without delivery, a threatened miscarriage. Let's look at impending coronary syndrome, impending delirium tremors, impending myocardial infarction. So when we look at those terms in the index, we can find some conditions. But the big thing is if there's not a term under impending or threatened and it didn't actually happen, then you do not code it. If the subterm isn't listed, you code the existing underlying condition and not the condition described as impending or threatened. And look at this second example on 89, impending fracture of the humerus due to multiple myeloma. There's no impending fracture code here. And if we go to fracture, and it just so happens that a fracture from a multiple myeloma is pathological, and if I go to fracture, pathological, and then look for impending, there is not a code for that. So what I actually do is I code the multiple myeloma. I can't code an impending fracture due to multiple myeloma, so I have to code the multiple myeloma. Number 12 on page 89 tells you that every ICD-10 code is reported only once. That means it's listed once and only once on the chart. And then we have looked at laterality and talked about laterality. So on page 90, 14, documentation for BMI, non-pressure ulcers, and pressure ulcer stages. Now, body mass index, BMI, okay, if I go to body, I will see mass index, BMI, and there are ranges for adults and for pediatric patients. BMI is usually often documented in very obese patients, or sometimes for very anorexic or malnourished patients. Usually there is a required BMI before insurance companies will approve bariatric surgery. Usually in those cases the physicians are very specific in their H&Ps and they document that BMI. However, a physician may document obesity, and then there may be a specific nurse or the dietitian who actually documents the BMI. And we actually can use the documentation by that specified person to code BMI. Now, if the physician doesn't document obesity, but for some reason BMI is documented, you can't code the BMI. You need the physician to have some documentation that supports the reason that that BMI was documented. And without it, you're either not going to code the BMI or you are going to generate a query asking the physician to specify the reason that the BMI was performed. And usually a BMI would not be performed unless the physician requested it. Patients also develop pressure and non-pressure ulcers. So I'm going to go to ulcer. And when we look at pressure ulcers, we code not only the location of that pressure ulcer, but the stage. For instance, if I go to pressure ulcer of the ankle, I can see that and we'll go over this in much more detail when we're coding in this chapter. But I can see that I am able to code the staging of that. And the important thing about this is that the physician may document the stage of the ulcer, or nursing may document the stage of the ulcer. Nursing is very focused on skin integrity. They actually do skin assessments on all of their patients, and particularly patients who are at risk. They examine them the minute they come in to assess their skin, and if there's anything that looks out of place, they will be documenting that. So as long as the physician documents the pressure ulcer, and if we go to ulcer, and then pressure ulcer, ulcer pressure, and then stage, we can see the different stages for these pressure ulcers. You can use nursing documentation for pressure ulcer staging. You always code to the highest stage that the patient has. Now, number 15 on page 90 talks about syndromes. And basically in the index you can put in syndrome, and there is a pretty long list of all different kinds of syndromes that are listed here. If the alphabetical index doesn't have a code for the syndrome, then you're going to assign codes for those manifestations of that syndrome. Then number 16 talks about documentation of complications of care. And this is very important. When we assign codes, it is always based on the provider's documentation of the relationship between any condition and the care or the procedure. The guidelines extend to any complication of care regardless of the chapter the code is located in. It's very important to note that not all conditions that occur either during or following care or surgery are complications. There has to be a cause and effect relationship documented between the care that was provided and the condition, and an indication in the documentation that that condition is a complication. If you have any question about that, if there's any question about that, then you always query that provider for additional clarification. In this example on the top of page 91, this patient is being seen for routine post-surgical care. The patient had an appendectomy 5 days ago. So this patient is coming into the clinic, and when they're seen in the clinic, they have a UTI. And you'll notice that the UTI is coded, but there is not a code for a complication because the urinary tract infection is not documented as a complication, so we're not coding it that way. Now look at number 17 on page 91, borderline diagnosis. If the provider documents that a diagnosis is borderline at the time of discharge, the diagnosis is coded as confirmed unless the classification system provides a specific entry. And the example is diabetes. So let's look at diabetes type 2 . No, that's not it. What we actually do is we put in the term borderline. So you can see when we put in borderline, there's a code for diabetes mellitus, and that actually codes to other abnormal glucose, hypertension, and that codes to elevated blood pressure without a diagnosis of hypertension. Then we have osteopenia, pelvis with obstruction during labor. So, typically we look up the term borderline. If you have documentation of a condition and there is not a borderline diagnosis here, then you code it as confirmed. And that's what this guideline tells you. Borderline conditions are not uncertain diagnoses. There's no distinction made in the patient care setting, inpatient versus outpatient. If the documentation is unclear regarding a borderline condition, then you should query the physician. On the bottom of page 91, it talks about the use of signs and symptoms and unspecified conditions. We have gone over when we use signs and symptoms. So read this information. It'll support what we have already looked at. Now for this lecture, I want you to exercise 5-7. I want you to code number 1 and number 3 and number 9. And that will conclude this lecture. In our next lecture, we're actually going to begin with the guidelines for the selection of the principal diagnosis. And that will conclude this lecture.